A very good evening. Now we are going to discuss about family planning and contraception. So, what is the need for the contraception? India, with only 2.4% of global land mass, is the most populous country in the world, and population is rising by 16 million every year. Such a large population expansion adversely affects national economy and the health of mother as well as the child. According to NFHS, that is National Family Health Survey 5, the unmet needs for contraception is about 9.4%. Therefore, controlling the population growth is utmost important. The term contraception includes temporary and permanent measures designed to prevent pregnancy from unprotected sexual intercourse. So, this chart shows that female sterilization contributes about 34% usage in India. Male sterilization, which is the most effective contraception method, counts just 1%. IUCD 2%, condom 6%, any traditional method 7%, pills 4%, and non users includes around 46% of the couples. So, the most common method that Indian population uses is female sterilization. Coming to types of oral contraceptive pills are divided into hormonal or steroidal pills and non-hormonal pills, which include sandchromin, also known as ormeloxifene. Hormonal contraceptive includes combined OCPs or COCPs, POPs or progesterone-only pills, and emergency contraceptives. Hormonal contraceptive contains two hormones, that is progestin and an estrogen. Like the natural hormones, progesterone and estrogen in the women's body. Estrogen component of OCP. Estradiol is the most potent natural estrogen and majorly secreted by the ovaries. The major obstacle to use sex steroid for contraception was reduced activity of the compounds when given orally. A major breakthrough occurred when it was discovered that the addition of ethinyl group at 17th position increases the oral bioavailability of estrogen. The ethinyl estradiol is very potent oral estrogen and is the form of estrogen in most OCPs or oral contraceptive pills. Now coming to progesterone component of OCP, in 1951 it was demonstrated that removal of 19th carbon from ethiosterone, which is an orally active testosterone, will form norethindrone and change the effect of androgen to progesterone. The androgenic properties of these compounds, however, were not totally eliminated, and minimal anabolic and androgenic potential remains within the structure. So, these androgenic activity causes side effects of oral contraceptive pills. Now coming to mechanism of action of OCPs, major mechanism of action is prevention of ovulation by inhibiting GnRH secretion. Now, independently, estrogen component and progesterone component have some mechanism of actions. Estrogen component suppresses FSH secretion. Therefore, it prevents the formation of dominant follicle. It also stabilizes the endometrium, thus decreases irregular shedding and breakthrough bleeding. And this is the reason we use this for regularizing the menstrual cycle in case of PCOS and irregular menses. It also potentiates the action of progesterone by increasing the concentration of intracellular progesterone receptors. Progesterone causes suppression of LH and therefore prevents ovulation. It causes uterine endometrium atrophy and makes the endometrium not receptive for ovum implantation. It thickens the cervical mucus, therefore inhibits the sperm ascent. Now, OCP is divided based on the dose into low dose, very low dose and high dose pills, while based on the generation of progesterone, it is divided into first generation OCP, second generation OCP, third generation OCP and fourth generation OCP. First generation includes norethindrone and norethindrone. Second generation includes norgestrel, levonorgestrel, and which is the levonorgestrel is the most common progesterone used in OCPs. Third generation includes desogestrel, gestodine, and norgestimate. Fourth generation includes drospirenone and dinogest. as we increase the generation, the androgenic side effects reduces and anti-androgenic activity is maximum in fourth generation OCPs. Based on the phase, OCP is advised. They are divided into monophasic, biphasic, and triphasic. Monophasic means the dose of estrogen and progesterone remains same throughout the month, while biphasic contains constant dose of 35 microgram of ethinyl estradiol and lesser dose of progesterone for the first 10 days. So for first 10 days, where estrogen dependent phase of the menstrual cycle is dominant, we give progesterone in lesser amount, and in the next phase of the cycle, that is in the luteal phase, we increase the dose of the progesterone component. But this is associated with high failure rate and it is not available in India. Triphasic are popular and available in most of the countries including India, and the brand name under which triphasic pills are available is Tricular. So this is Tricular. This pack contains three color tablets, that is red, white and yellow, and the first 6 tablets contains 30 microgram of ethinyl estradiol and 50 microgram of LNG. So in the first half, levonorgestrel or the progesterone component is lesser in amount. Now next 5 tablets, so these are the 6 tablets where the progesterone component is 50 microgram, and in the next line you can see 5 white tablets. These 5 white tablets contain more amount of ethinyl estradiol, that is 40 micrograms, and more amount of levonorgestrel, that is 75 microgram of LNG. And the last column of tablets, that is 10 tablets, contains 30 microgram of ethinyl estradiol with 125 microgram of levonorgestrel. So the ratio is 30 40 30, 50 75 125. This is followed by a pill free interval. So these 6 tablets, 5 tablets and 10 tablets makes 21 tablets. A pack is having 21 tablets with 7 tablets absent, means this is a pill free interval. These varying amount of estrogen and progesterone component provides better cycle control and prevents breakthrough bleeding. This is Tricular. Now types on the basis of dose of estrogen, as we have already discussed, the usual dose of estrogen component in OCP is 30 microgram. High dose pills where ethinyl estradiol is 50 microgram. Low dose pills where the dose is less than 50 microgram, usually 20 microgram. And very low dose pill where ethinyl estradiol is just 10 microgram. Effectiveness of any contraceptive method is determined by 2 factors. First one is perfect use and second one is typical use. Perfect use means when the pregnancy rates or the failure rates, when the method is used perfectly, consistently, exactly according to the directions, which is not possible. While common use or typical use means when it is used by an average person who does not always use the method consistently and correctly. Now what is Pearl Index? Pearl Index is defined as the number of contraceptive failure per 100 women years of exposure and uses as the denominator the total months or the cycles of exposure from the initiation of the product to the end of the study or the discontinuation of the product. The lesser is the Pearl Index, the safer the method of contraception is. Now let's discuss the failure rates of different combined OC pills. For OC pills, failure rate with common use is 7 pregnancies per 100 women. With perfect use, it reduces to 1 pregnancy per 100 women. So the Pearl Index for common use is 7 and for perfect use it is 1. Now let's learn about some popular oral contraceptive pills and their composition. First one is Mala D or Mala N. Both contain same amount of estrogen component as well as progesterone component, but the Mala D is available at a cost of rupees 3 per pack, while Mala N is available under family planning program free of cost. Mala and Mala D contains levonorgestrel, that is 150 microgram, ethinyl estradiol 30 microgram. Mala N is supplied free of cost and Mala D is available 3 rupees per pack. Each strip of Mala N and Mala D contains 21 hormonal pills. So the number of hormonal pills is 21, while the 7 black pills are non-hormonal pills which has ferrous fumarate in it. Second is overall L, overall G. Overall L contains the same components, ethinyl estradiol and LNG, in the same dose 30 and 150, but it has only 21 tablets. 7 ferrous fumarate tablets are absent in this pack. While overall G contains 21 tablets, it has G for great. Great means the dose of ethinyl estradiol is greater than overall L and it is 50 micrograms. While progesterone component is also different. In overall L, we have L for LNG and in overall G, we have norgestrel in a dose of 500 micrograms. Uses. Overall G is used for menorrhagia and contraception in females requiring high estrogen. So in what conditions we would like to give a patient more estrogen? In any of those conditions where when patient is on some other drug which has enzyme inducing activity and it metabolizes estrogen easily. So these drugs are anti-tubercular drugs and anti-epileptic drugs. So whenever a patient is on ATT or an anti-epileptic drug, then chances of contraception failure with OCP is more. So we would like to give these patients with more amount of ethinyl estradiol, that is 50 micrograms, and norgestrel, that is 500 micrograms, and we will advise overall G. Next is Familon. Familon contains ethinyl estradiol, but the progesterone component is changed to desogestrel. So Familon has 21 tablets containing ethinyl estradiol 20 microgram, that is low dose, and desogestrel 150 micrograms. So this is Familon. Desogestrel is fourth generation. Desogestrel is fourth generation OCP. No, third generation OCP. So it has least androgenic side effects. While 4th generation OCPs have anti-androgenic activity, so the androgenic side effects are not seen with 4th generation OCPs. Hence, Familon contains 21 tablets which have ethinyl estradiol and desogestrel, and we will give this Familon to those ladies with irregular menses or PCOS. Next is Novelon. Novelon has desogestrel and ethinyl estradiol just like Familon, but the ethinyl estradiol is slightly more as compared to Familon. So the ethinyl estradiol is 30 microgram and desogestrel has 50 micrograms of progesterone component. Another formulation is Minis. Minis contains ethinyl estradiol in a dose of 50 micrograms only and gestodine, which is also a third generation progesterone in a dose 60 micrograms. So this is Minis. Fourth generation of progesterone includes drospirenone, which is a spironolactone derivative, and it has progesterone agonist and antagonist at mineralocorticoid receptors and androgenic receptors. So in those situations, it is to be used cautiously in females with renal and hepatic disease because of risk of hyperkalemia due to antagonistic activity at mineralocorticoid receptors. It also leads to weight loss due to its diuretic action. Due to anti-androgenic activity, it reduces acne. Hence, it is good in females with PCOS, with obesity, and PMDD. PMDD is premenstrual dysmorphic disorders, and it is slightly costly. So this is Yaz and Yasmin. Yaz is one pack consisting of 24 plus 4 tablets. So these 24 tablets contains drospirenone, which is a 4th generation progesterone, and ethinyl estradiol 20 micrograms. So what options do we have in PCOS patients? We can give Familon, we can give Novelon, we can give Yas, we can give Yasmin also. Yasmin contains 21 hormonal tablets. Each tablet consists of drospirenone 3 mg. So in both of these tablets, drospirenone is 3 mg, while ethinyl estradiol is Yas is 20 microgram, and the name is slightly bigger for Yasmin. So dose is more for ethinyl estradiol, that is 30 microgram, and the number of tablets is 28 tablets in Yas and 21 tablets in Yasmin. 28 tablets is divided into two parts, that is 24 hormonal tablets and 4 inert tablets. Nowadays, estradiol valerate, an esterified form of estradiol, is also available with significant potency, and it can be used in conditions like Asherman syndrome. Another one is Clara. Clara contains Dynogest combined with estradiol valerate as an oral contraceptive, and it is not available in India. This Clara has 28 film coated tablets, and it is available for oral use. It consists of 4 phases, with ethinyl estradiol valerate dose decreasing from 3 mg to 1 mg over 26 days, and Dynogest provided in a dose of 2 mg on day 3 to 7 and 3 mg on day 8 to 24. This phasic administration of estradiol valerate and Dynogest provides ovulation inhibition and a bleeding profile comparable to a standard low-dose monophasic oral contraceptive. Now there is one unclassified progestin known as cyproterone acetate, where the mechanism of action of cyproterone is anti-androgenic. It suppresses the actions of testosterone and its metabolite DHT or dihydrotestosterone on tissues. So this is cyproterone acetate, which is an anti-androgen. Cyproterone acetate is present in diene 35, also known as crimson 35. This diene 35 contains cyproterone acetate in a dose of 2 mg and ethinyl estradiol 35 micrograms. So this anti-androgenic activity of cyproterone acetate can be used in PCOS patients. Given in patient with PCOS due to its anti-androgenic properties, it is available in low-dose OCP formulation, and WHO recommends that combined OCPs with 35 microgram of ethinyl estradiol and cyproterone acetate should only be used when treating moderate to severe hirsutism or acne. So it is used in severe form or moderate form of PCOS where acne is more. For contraception, irregular menstrual cycles, and mild to moderate hirsutism, other preparations like Familon, Novelon, Yasmin, Yas can be advised. Now there is a regime, extended continuous OCP regime, in which a standard 21 regimen are associated with decrease in menstrual discomforts, headaches and bloating. This extended regime exposure suppresses gonadotropin and follicular activity to a greater degree, and this can be used in patients with good compliance. Greater reduction in follicular activity can reduce the possibility of breakthrough ovulation and contraceptive failure. So this extended use regimen includes 84 hormonal pills in a row, one on each day. These are hormonal pills in 4 monthly pack, and users of 28 pill packs do not take non-hormonal pills. Means it can be used continuously for a period of 4 months. A regimen is also available that supplies a package containing the number of pills required for 80 days of daily administration and reduction of menstrual frequency to 4 per year. This is known as seasonal, where there is 20 microgram of ethinyl estradiol and 100 microgram of levonorgestrel with 7 placebo pills. Seasonic is another extended regimen pill. So this is Seasonic, where levonorgestrel and estradiol is present in a dose of 150 microgram and 30 microgram, with ethinyl estradiol 10 microgram also. And this is 2 extended cycle tablet dispenser which contains 91 pills. Another one is Seasonal, which is also an extended cycle table dispenser. Now coming to counseling of the patient, thorough counseling about bleeding changes and other side effects is an important part of providing the method. We have to counsel the patient about bleeding changes, side effects of the pill that we have prescribed. Counseling about bleeding changes may be the most important, as this can lead to stoppage of pill use. And we have to describe the most common side effect in the first few months: bleeding at unexpected interval, that is irregular bleeding can occur with OCP use. Then lighter, shorter, more regular monthly bleeding can occur, and because of estrogen component, patient can have headache, breast tenderness, weight changes, etc. Now, how to start taking pill? First one is conventional method, then we have quick start, immediate or same day start method. Conventional method, the hormonal contraceptive should be ideally started no later than 5th day of the menstrual cycle. That is, we have to start the OC pill within 5 days of the stoppage of the menstrual cycle. And if started in these days, then no backup method or barrier method is required to be used. If it is started on first day, ideally OCP should be started on the first day of the menses, which ensures immediate protection. Also, we can start on first Sunday. The Sunday start package beginning on the first Sunday following the onset of menstruation can be easier to remember, and it usually avoids menstrual bleeding on weekends. If the Sunday start is used, it is advised to use added protection for the first week of use in India. And Sunday start is not preferred in India. We try to tell the patient to use first day start method. Next is quick start method, immediate or the same day start method. Many clinicians advocate that the pills should be started on the day the patient receives her prescription, regardless of the patient's day in her cycle. It should be combined with backup method for the first week, preferably condoms. Pregnancy should be ruled out before starting OC pills through quick start method or same day start method. Now, what instructions would you like to give to the patient? So we have to advise, take one pill each day until the pack is empty. Discuss cues for taking a pill every day, linking pill taking to a daily activity. Like take a pill while cleaning your teeth may help her to remember. Taking pills at the same time each day also reduce some side effects. Take pills with food or bedtime to help avoid nausea, and provide backup method and explain its use to her. So, a OC pill should be taken on the same day to avoid side effects, and it can be taken with food or at bedtime. And backup method is also advised for at least 1 week. Now, how would you like to plan for the next visit and follow-up? The first visit is at 3 months. So, if we are advising patient OC pills, then we can give OC pills for 3 months, and the next visit is after 3 months. This offers an opportunity to answer any questions, help with any problems, and check on correct use. Healthy young women with no risk factors need to be seen every 12 months for exclusion of problems by history, measurement of BP, urine analysis, breast examination, liver palpation as it can deranged liver function, pelvic examination with pap smear if indicated. Women with risk factors should be seen every 6 months. So, if no risk factors are present, then annual checkup is recommended, and if risk factors are present, then every 6-month visit is advised by appropriately trained health professional for screening of problems by history, blood pressure measurement, breast and pelvic examinations. So, what to do when pills are missed? So, if 1 or 2 pills are missed, then as soon as the patient remembers that she has missed a pill, take a hormonal pill as soon as possible. There is little or no risk of pregnancy. If 3 or more pills are missed in a row in the first or second week, so this duration is important. Whether the pill is missed in the first or second week, or the third week. If more than 3 pills are missed in the first or second week, then take hormonal pill as soon as possible and add backup method for next 7 days. And if she had coitus in the past 5 days, then emergency contraceptive pills are also advised. So in the first and second week, hormonal pill plus backup method for 7 days plus emergency contraceptive if had coitus for in the last 5 days. But what if the pills 3 or more are missed in the third week? In this situation, take a hormonal pill as soon as possible. Finish all hormonal pills in the pack. Throw away the 7 non-hormonal pills in the 28 pill pack and start a new pack. the next day. Use a backup method for the next 7 days. Also, if she had coitus in the past 5 days, she can consider emergency contraceptive pills. So, if of 3 or more pills are missed in third week, then hormonal pill is given. Along with that, we have to complete the hormonal pill pack. We have to discard these 7 non-hormonal pills and use the new pack immediately. Plus, backup method and emergency contraceptive is also advised. For pills with low dose estrogen, that is 10 or 20 micrograms of ethinyl estradiol, women missing one pill should follow the same guidance as for missing one or two 30 to 35 microgram pills. Women missing more than 2 pills should follow the same guidance for missing 3 or more 30 to 35 microgram pills. What if after taking the pill within 2 hours patient is having severe vomiting and diarrhea? If she vomits within 2 hours after taking the pill, she should take another pill as soon as possible. And if she has vomiting or diarrhea for more than 2 days, follow instruction of 3 or more missed pills as advised previously. So, one of the most common side effect of OC pill is breakthrough bleeding. This occurs as a consequence of progesterone-induced atrophic endometrium with vascular fragility. This endometrium and the blood vessels within it are prone to break down and lead to asynchronous bleeding. The most frequently encountered breakthrough bleeding occurs in the initial months of use. Incidence is higher in women who smoke and with use of low-dose oral contraceptives. Cervical infection can be the another cause of breakthrough bleeding, and its prevalence is higher among OC pill users who report breakthrough bleeding. So, how will you manage this breakthrough bleeding which is occurring in the first initial month of use? If the bleeding occurs just before the end of the pill cycle, it can be managed by having the patient to stop the pills. Then we will wait for 7 days and then we start a new cycle. If breakthrough bleeding is prolonged and it is getting aggravated, control of bleeding can be achieved by exogenous estrogen. Conjugated estrogen, that is 1.25 milligram or estradiol 2 milligram, is administered daily for 7 days when the bleeding is present, no matter whether the patient is in her pill cycle. Now, there are certain non-contraceptive benefits of hormonal contraceptives. So, what are these? Hormonal contraceptives or OCPs reduces the risk of endometrial, ovarian and colorectal cancer, but not cervical cancer. There is, due to presence of estrogen components, the bone mineral density is increased in older women if OCP is given. It also induces amenorrhea for lifestyle considerations. It regularizes the menstrual cycle. It prevents menstrual migraines. We can use OCPs for treatment of acne, treatment of bleeding for leiomyoma, treatment of dysmenorrhea, treatment of hirsutism, that is the symptom of PCOS, hirsutism, acne, irregular menses. We can use this for treatment of menorrhagia, treatment of pelvic pain from endometriosis, and treatment of PMS or premenstrual syndrome. So, what is postpartum contraception? So, when the patient is fully breastfeeding, a contraceptive method should be used beginning in the 3rd month postpartum. While when partial breastfeeding or no breastfeeding is there, a contraceptive method should be started in the 3rd postpartum week. So, rule of 3 is applied. If fully breastfeeding, then contraceptive method 3rd month postpartum. If not breastfeeding, then 3rd week postpartum. After the spontaneous and elective termination of pregnancy of less than 12 weeks, steroid contraception can be started immediately. So, in case of abortion, where the gestational age is less than 12 weeks, we can advise contraceptive pills immediately. After a pregnancy of more than 12 weeks, 3rd postpartum week rule should be followed to avoid postpartum risk of venous thromboembolism. So, fully breastfeeding, 3rd month postpartum. Not breastfeeding or partial breastfeeding, 3rd week postpartum. Less than 12 week abortion can be started immediately. More than 12 week abortion, 3rd week postpartum. Just like partial breastfeeding or no breastfeeding, because if given in the earlier period, it can cause venous thromboembolism. So why OCPs are being avoided in postpartum period? OCPs contains estrogen and progesterone, and it has been demonstrated that they reduces the quantity as well as the quality of lactation in the postpartum woman. There has been a concern regarding the potential hazard of transfer of contraceptive steroid to the infant through breast milk, although no adverse effect has yet not been identified, but it can be transmitted to breast milk also. The risk of venous thromboembolism begins shortly after conception, is maintained throughout pregnancy, and it is highest in the first week postpartum and then gradually declines. Thus, estrogen and progesterone are not advised in first month of pregnancy. The recommendation is that non-breastfeeding mothers use a progesterone only contraceptive method beginning in the third week postpartum. A change to a combination estrogen progesterone method can be initiated in the 7th week postpartum. So progesterone only contraceptive can be advised in third postpartum week, but OCPs after 7th week in the postpartum period. Why POPs or progesterone only pills are preferred in the postpartum period? In contrast to OCPs, progesterone only mini pill provides a modest boost to milk production. So the progesterone components induces milk production, and women using mini pill breastfeeds longer at supplementary feeding at a later time. The combination of lactation and progesterone only mini pill is associated with near total contraceptive efficacy. The mini pill can protect against bone loss with lactation and potential advantage in undernourished women. Because of slightly positive impact on lactation, mini pill can be started immediately after delivery. Progesterone alone do not increase the risk of venous thrombosis. It is the estrogen component. Now, there are certain drug interactions with OCPs, just like some anti-epileptic drugs and anti-tubercular drugs, and these drugs induces hepatic cytochrome P450 enzyme and thus increases the metabolism of OCP and reducing OCP efficacy. So what are these drugs? These are anti-epileptic drugs like phenytoin, phenobarbital, carbamazepine, oxcarbazepine, felbamate, topiramate, and certain antifungal agents like grisofulvin, ketoconazole, and itraconazole. Ampicillin and tetracycline were implicated in numerous case reports of OC failure. What ampicillin and tetracycline do is that they kill the gut bacteria, primarily Clostridia, that are responsible for hydrolysis of steroid glucuronides in the intestine, which allows reabsorption of the steroid through enterohepatic circulation and hence causes OC failure. The interactions of antiretroviral drugs with contraceptive steroids are complex. Some of the drugs increases plasma steroids levels and some reduce them. Now, OCP and neoplasia. Coming to endometrial carcinoma, the use of oral contraception protects against endometrial cancer. The use for at least 12 months reduces the risk of developing endometrial cancer by 50%, with the greatest protective effect gained by use for more than 3 years. So, if OCP is used for at least 12 months, then the risk of endometrial cancer is reduced by 50%, and the greatest effect is seen in the first 3 years. This protection persists for 20 or more years after discontinuation and greatest in women at highest risk, that is nulliparous and low parity women. This protection is equally protective for all three major histological types of endometrial cancers, that is adenocarcinoma, adenoacanthoma, and adenosquamous cancers. Now, for ovarian cancers, increased exposure of OCPs can reduce ovarian cancer risk by 40% as compared to non-users. This protective effect lasts for around 20 years after stopping the medication. So, endometrial cancer risk is reduced by 50%, ovarian cancer risk is reduced by 40%, and cancer cervix risk is slightly increased. After a woman stops using OCPs, the risk decreases. By 10 years after stopping OCPs, a former OCP user has the same risk of cervical cancer as never used OCP user. So what are the factors that apparently have increased risk due to use of OCPs? First one is enhanced detection of disease. Because OC users have more frequent pap smears, hence apparent risk is increased. Women who used OCPs typically start sexual relations at younger age, and some studies report that these females have more than one sexual partner. These factor increases one's chance of acquiring HPV, which is the most important risk for cervical cancer. Hence, apparently the risk is increased. Now coming to breast cancer, there is a large volume of conflicting literature about this. Women who used OCPs for more than 10 years faces the same risk as non-users. In contrast, some studies find that the current users of OCPs and women who have OCPs within the last 10 years are slightly more likely to be diagnosed with breast cancer, as more frequently breast examination is done in OCP users. The slight increased risk could be influenced by detection and surveillance bias only. The risk of colorectal cancer is reduced to around 40% after 8 years of use of oral contraceptive pills, and steroid contraception should be offered to a woman with strong family history of colorectal cancers. Now coming to progesterone only pills, also known as the minipill. Minipill contains a small amount of progestational agent, and it must be taken daily and in a continuous fashion and on the same time. And if a pill is missed, then new method to be advised to the patient. So what is the mechanism of action of POPs? POPs is progesterone only pills. So the mechanism of action is due to progesterone component. Small amount of progesterone in POPs will have a significant impact on those tissues very sensitive to female sex steroids like estrogen and progesterone. So it changes cervical mucus, it makes it thick and causes endometrium atrophy, which makes the endometrium non-receptive for implantation. The endometrium involutes and becomes hostile to implantation, while cervical mucus becomes thick and impermeable to the entry of the sperms. So what is the efficacy of progesterone only pills? So it is different with breastfeeding and non-breastfeeding females. With breastfeeding females, because breastfeeding also causes a kind of contraception known as lactational amenorrhea or LAM method. Breastfeeding with perfect use 0.3, with typical use 1 per 100 women, while non-breastfeeding 3 to 10 per 100 women years. So what are the side effects of OCPs? Side effect of OCPs includes changing in the bleeding pattern. For breastfeeding women, lengthened postpartum amenorrhea, frequent bleeding or irregular bleeding, headache, dizziness, mood changes, breast tenderness, abdominal pain and nausea. So how to start taking OCPs? So it is different in fully breastfeeding female, partially breastfeeding female and non-breastfeeding female. If a female is fully breastfeeding her child and less than 6 months after giving birth, then we can start POPs anytime and there is no need for backup method. But if more than 6 months have passed, then we can start anytime she is reasonably sure that she is not pregnant, and backup method to be advised for at least 48 hours. So in OCPs we are advising backup method for 7 days, but here we are advising backup method for only 48 hours. In partially breastfeeding female, monthly bleeding not returned or returned, it is important. If monthly bleeding has not returned, then we can start anytime if reasonably sure that she is not pregnant and use backup method for 48 hours. But if patient has resumed her bleeding, then we have to start it in the first 5 days of the menstrual cycle and no backup method is used. And if started after 5 days, then backup method is advised. So if the patient is not breastfeeding, then we have to check less than 4 weeks or more than 4 weeks. If less than 4 weeks, then start POP anytime and no need for backup method. And if more than 4 weeks, then we have to check whether monthly bleeding has started or not. If monthly bleeding has returned, then in the first 5 days of the menstrual cycle, no backup method is required, and after 5 days, backup method is required for 48 hours. And if the monthly bleeding has not returned yet, even after 4 weeks, then we can start anytime and backup method is advised for 2 days. So now when to start POPs? Immediately after miscarriage or abortion, we have to start immediately. Starting within first 7 days of abortion, no need for backup method. More than 7 days, we can advise 2 days backup method. So this is the pregnancy checklist that we have to ask to our patient. Ask the client question number 1 to 6. As soon as the client answers Yes to any question, stop and follow the instructions below. Did your last monthly bleeding started within past 7 days? No. Then we can start the contraceptive method anytime. Have you abstained from sexual intercourse since your last monthly bleeding, delivery, abortion or miscarriage? No. Have you ever been a reliable contraceptive method consistently correcting since your last monthly bleeding, delivery, abortion, miscarriage? Have you had the baby in the last 4 weeks? Did you have a baby less than 6 months ago and you are fully or nearly fully breastfeeding and have no monthly bleeding since then? Have you had a miscarriage or abortion in the past 7 days? If the client is planning to use a copper bearing IUD, the 7-day window is expanded to 12 days. And if the client answered no to all the questions, pregnancy cannot be ruled out. Using the checklist, rule out pregnancy first and then advise the method. If the client answered yes to at least one of the questions, you can reasonably sure she is not pregnant. So this is a progesterone pill, that is norethindrone only pill, which contains norethindrone in a dose of 35 micrograms per day. So in case of PCOS with irregular menses and patient is coming with UPT negative and amenorrhea, we advise patient norethindrone in a dose of 10 milligram per day. But when we use norethindrone as for contraception, we have to advise it at least 35 micrograms per day, and this is norethindrone only pill. This is desogestrel only pill, also known as Cerazette. It is frequently asked in the exams. Cerazette contains 75 microgram of desogestrel, which is the third generation progesterone, and the missed pill window is 12 hours. So if the pill is missed, then we have to take the missed pill within 12 hours, and if not taken, then the method is gone. Drospirenone only pills, coming with a brand name of Slynd. It contains 4 milligrams of drospirenone, and it has to be taken for 24 days followed by a gap of 4 days. The pack contains 24 pills and it reliably inhibits ovulation. Missed pill window is 24 hours. Approximately 40% of the patients will ovulate normally. Because of the low dose, the mini pill must be taken every day at the same time of the day. The changes in the cervical mucus requires 2 to 4 hours to take effect, and impermeability diminishes 22 hours after administration. By 24 hours, some sperm penetration can occur. So the chances of failure is more with progesterone only pills if not used correctly. So what if a pill is missed in these women with POPs? If a woman is 3 or more hours late taking the pill, 12 or more hours late taking a POP containing desogestrel 75 milligrams or Cerazette, or if she misses a pill completely, she should follow the instructions below. Take the missed pill ASAP. Keep taking pills as usual, one each day. She may take 2 pills at the same time or on the same day. If the patient has resumed menses, she should use a backup method, and if she had a coitus in the last 5 days, then emergency contraceptive is advised. Thank you.